presentation's finished, pop your hand up to ask questions. And please, as usual, can I just ask that everyone stays muted unless they are speaking, so that we can avoid there being any background noise on the recording at all. So without further ado, I shall introduce the session this afternoon. So we're going to be hearing from Ruth and Rebecca on this topics of, low carbon pathways in malnutrition and frailty. Ruth is a dietitian who's worked in the NHS for 10 years now. She's worked across a variety of settings and is currently working in prescribing support across Southeast London. She's been interested in sustainability for a number of years and co-leads the Nutrition and Dietetics Green Team, and is a member of the Reducing Single-Use Plastics Working Group at Guy's and St Thomas's. And she's also resource officer for the BDA Sustainable Diets Group. In September last year, you might have spotted an article by Ruth in the Dietetics Today magazine, for those of you who receive that as British Dietetic Association members, which looked at the environmental impact of ONS packaging. Rebecca is also a dietitian, and she's worked in the NHS for over 15 years. Her interests include the relationship with food and drink across the lifespan, especially in relation to prescribed food and drink. She works in clinical practice at the Royal Free London CAMHS Eating Disorder Service and as a regional AHP prescribing advisor. Rebecca is on the professional committee of the British Dietetic Association and is a research officer for the BDA Optimising Nutrition Prescribing Group. A little fun fact about Rebecca is that she was a founding member of Junior Friends of the Earth, which included a Save the Planet fancy dress march. So I'm sure you agree that Ruth and Rebecca are just the right people to speak to us on this topic this afternoon. So thank you both.
Hello everybody, and thank you for joining us today. I'm just going to quickly run through the content of our talk, and then I'll hand over to Rebecca for the first part. So we're going to be starting off by kind of understanding the principles of sustainable healthcare. Then we'll look at concerns that we might have about any existing pathways of care and whether they should be labelled high carbon. Then we'll touch on low carbon pathways of care and what we should be doing. And then finally, what you can do at the end. So I'm going to hand over to Rebecca for the first part.
Thanks, Ruth. So we've got quite a mixed audience today. So I just wanted to go through the sort of 4 principles of sustainable healthcare. I know many of you will have seen this before, but it might be new to some people. So we'd really think about, number 1, prevention, and that can be across all of the population. 2, patient self-care, and 3, lean service delivery. And then fourthly, low carbon alternatives. So what we've done is we've thought about our topic today along these lines. Next slide, please. You'll see that we've recreated the diagram here, but thinking a bit more context specific. So I've just put in the prevention thing for the whole population, 1 blue dot, which is a really excellent resource, and the Eat Well Guide. And this is for the whole population. And if we think more specifically about self-care, and in particular for older adults and frailty, we're beginning to get a lot more specific. We are going to be talking about oral nutritional supplements today, in part because that is part of potentially malnutrition and frailty management of older adults. But really, oral nutritional supplements can be used in a number of conditions, and it is quite specific according to the rationale. Then So you can apply it to other nutritional products. So cow's milk protein allergy, chew feeds. Some of the principles that we're talking today have much broader applicability, but today we're really talking about older adults and frailty. So I've put some really fabulous resources here to signpost you to. So Eating and Drinking Aging Well and Muscle Health, Nutrition and Aging, produced by the Older People's Group of the British Dietetic Association. Some really fab resources there in terms of self-care. And we've also written an article that was published last year in BMJ Nutrition, which I think really starts to think about the sort of more preventative actions and the self-care follow-on. But what we're really going to be thinking about today is the lower half of the diagram, and in particular lean service delivery and low carbon alternatives. Next slide, please.
Let's stop.
So lean service delivery, and I've got a question mark there because this is quite a sort of thorny topic. As many of you might well be aware, we've got quite an unusual procurement and service model for nutrition and dietetics, in that we know that our tube-fed patients need home care once they leave the hospital, and that the oral nutritional supplements are very much included in those contracts, and that they're quite a complex offer in terms of both product and service, which is quite sort of challenging in procurement terms. And we know that these contracts are quite unusual because they're what we call loss leading. And this means that products like ONS are given away at penny or zero price in the hospital. Patients are discharged on them, and sometimes with good rationale, but sometimes with a very unclear or no rationale. And we know that the cost is then recouped in primary care. And this is quite a problematic procurement model because it sort of creates this level of a lot of supply in the acute side, and then very difficult to then sort of get control of things again back in primary care, or to really understand what's going on. We also know that in this procurement model, there's frequent legal challenges. Procuring these services is really quite challenging. There's a very small number of suppliers, and we know that there's very limited competition for these contracts. And I think it's worth acknowledging that the Competition and Markets Authority is currently investigating the companies in terms of infant formulas, and it is one and the same companies. So we know that we've got some problems with competition as well. And I think it's worth having at the back of our mind as we go through today, what is the potential impact of that? So we might return to that later, hopefully. But what is the future looking like? So from 2024 onwards, we've got new provision in public sector procurement, that 10% of any contract, the points will specifically be for sustainability and social value. So we've yet to see this in a number of contracts because they haven't come up for renewal yet. And so for a number of nutrition contracts, there is no sustainability and social value component, but we know that's certainly something that's going to be happening in the future. And we know that increasingly the ICS budgets will be shared. So at present, the ICSs are still very much forming, developing, and maturity in different ICSs, I would say, are very different stages. But increasingly, we think we're going to see conversations about how hospital getting free or penny-priced ONS affects finances. If there's zero cost to one part of the healthcare system and a high cost to another, how is that going to work for the healthcare system overall? And we've got increasing recognition of oversupply model and overprescribing of ONS. I was pleased to support NHSE with a potential definition of oversupply based on medicines. And I'm pleased that NHSE are going to be doing further work on this. So this is a really watch this space type comment. Next slide, please. So moving on. Oral nutritional supplements, we spent 188 million for the year to date, as shown in the slide, in primary care on standard adult oral nutritional supplements. And this is despite a lack of evidence for meaningful outcomes for older adults. We've put in tiny letters at the bottom the beast of an article, which is the NIHR paper, which really investigated and scrutinized and network meta-analysis and analysed all of the evidence, particularly for the population that we're talking about today. And they were quite cautious. So at present, we've got quite a sort of tricky situation with high cost, no real evidence of significant outcomes. And if we start thinking about the carbon footprint, it's not very encouraging either. It's quite easy to apply a carbon factor to that figure. And so you then sort of realise it's a bit of a triple whammy. So next slide, please. Talking a bit more about the evidence base in this area. I'm not expecting you to read all of this because there's a lot of information on this slide. But sort of needless to say that these are all neutral articles and studies where they have they're not industry funded, which I think is really significant in terms of really interrogating the data and the outcomes. And the sort of summary part of it is that across all these three, the Cochrane, NIHR, is really suggesting there's weak or uncertain evidence. And we really need to be doing a lot more in terms of understanding, say, the etiological basis of malnutrition and frailty, and really thinking about the outcomes that we look at. Next slide, please. So thinking a little bit more about rates of ONS prescribing, we've got this somewhat uncertain evidence base, or very uncertain evidence base. We've got this slightly bizarre procurement model, or challenging procurement model, I should say. And we've got at the other end this 188 million spend, which we're not really sure quite why we're spending quite as much with no meaningful outcomes. So this really got me to thinking about action bias. And what do I mean by action bias? This is a sort of potential factor where we think, what else is going on? Why is it still such a prevalent intervention? So I'd say really around action bias is that it addresses a really basic human need to do something. If we've got a loved one or family member who is sort of visibly losing weight, becoming weaker, and that sort of thing, then it's a really normal human reaction to want this problem fixed, want a really concrete action to make sure that the situation is being addressed. And I think as healthcare professionals, we sometimes also suffer from action bias. We need to do something and sort of cover ourselves almost. So we might want to write a prescription to show that we've done something. And what we'd really like to see is, increasingly thinking about, what that action should be. Many of you do excellent holistic assessments where you look at a whole range of interventions, some sort of thinking about dentures and mouth care, thinking about packages of care and all that type of thing. But really to say that it's a very normal human thing to need to do something, and this action bias. And that's one of the factors I think is why we continue to have quite high rates. Next slide, please. So thinking a little bit more about low carbon pathways, just in acknowledgement, the majority of ONS are dairy. I know there are a couple of plant-based alternatives. We're not looking at those. They're a relatively small segment of the prescribing, so we've largely just sort of disregarded them because we're really focusing this on sort of current prescribing practices. And then the other really important thing is for nutritionally vulnerable older adults who follow a mixed diet and where there's concern with frailty and malnutrition, prescribing choices should be reflect their normal dietary preferences. And I think it's really important to acknowledge as healthcare professionals, especially with an audience such as the one here today that might be really into saving the planet, that we might have some nutritional biases of our own around sort of wanting to reduce dairy. And whilst that might be the decision for you personally, in terms of prescribing and interventions, we'd want to be really careful about sort of respecting the dietary preference of older adults. And then when they're at their sort of weakest and most nutritionally vulnerable, that we wouldn't see that as the time to influence normal dietary habits. So thinking a bit more about these products, a majority of ONS are imported. They're not made in the UK, particularly the ready to drink. And then the smaller suppliers are more likely to manufacture their powders in the UK. So we've done some really basic calculations around carbon footprint, looking at weights and distances of the ready to drink versus powders made up with what is going to be likely more local milk. And obviously we're using a certain number of assumptions in this. It's a really complex science. It's kind of at its very beginning. So these calculations aren't perfect. But Ruth and I have discussed sort of having slight green imposter syndrome, that we don't necessarily feel that we're the experts in this. But equally, we're really keen that we make a start on thinking about this and investigating and really picking apart what is the carbon footprint of these products. So we've done our sort of best to date. Next slide, please. So thinking a bit more about low pathways of care and pathways of care in general, all good pathways of care should be patient-centred, with shared understanding of the problem, risks and goals. And I read a really interesting article recently about patients receiving nutrition support with very little agreement that weight gain would be the that they would want it to weight gain. And I think it's a real sort of thing around healthcare professional needing to measure something objective, that often weight gain becomes a really important sort of, this is the parameter by which we decide when to prescribe or not prescribe, which actually, if we don't have that shared understanding with the patient, is a really questionable practice, I would say. So we've got we should always have a shared understanding of the problem, the risks of doing nothing, and shared goals. And obviously, all patients, regardless of whether they have an ONS, need really comprehensive food-based management counselling in all cases, and to really understand the pros and cons of the different treatments. So obviously all good pathways of care should be based on evidence medicine. I know we all know this, but I think really frequently in nutrition we suffer from surrogate endpoints. What do I mean by that? Is that we tend to end up measuring things that are easier and cheaper, frankly, to measure, such as albumin, weight or BMI, versus actual clinical endpoints, by which I really mean how we sort of feel, function and survive. So we really need to just be a bit careful about sort of using surrogate endpoints and over-reliance on them, I suppose. So, I think we need to do a lot more to translate evidence-based into clinical process and organised care in this area, because at present we're struggling a wee bit, I would suggest. So next slide, please. So what should low carbon pathways of care look like? So first of all, there's a huge question about whether it should include ONS at all. For many patients, there may be many other holistic things that you can do to support that patient with their malnutrition and their frailty. But we know that sometimes an ONS is indicated, in which case we've had some thoughts on what the best thing to do based on low carbon. So if a prescription is appropriate, our scoping suggests that it's more than 3 times lower carbon with a ready to drink 1.5 kilocal per mil, and more than 2 times lower carbon than ready-to-drink ONS 2.4 kilocal per mil, a compact. So we know these powders, because of the distances involved and the weights, that the powders really are going to be have less of a carbon impact. Recognising that they're both dairy products, so that we haven't focused so much on that. And what I'd really say, and this is a really call to action, I suppose, I think we need greater scrutiny of the carbon impact of different service models and pathways. A while back, I was involved in doing some NHS right care style modelling for cow's milk protein allergy. And that proved really, really helpful in terms of unpicking some of the issues. And what I'd really like to see is approaches such as that. And then also, you know, things that Ruth's going to be talking about, such as life cycle analysis, to really unpick the carbon impact a lot more. Next slide, please. So Ruth, I think this is handing over to you.
Yes, thank you. So as Rebecca has already touched on, the powdered supplements are have a lower carbon footprint. And from experience in prescribing support, we sort of know that some of the barriers expressed regarding the use of powders are things like dexterity, so whether a patient can physically open sachets and use the shaker and mix them up. Memory, whether they would remember to go into the kitchen to make up the drinks. Accessibility, so whether a patient can get to the shops to buy milk to make them up. And cost, so sometimes patients say they have insufficient funds to buy fresh milk. I think we would just kind of highlight that if these things are kind of barriers that are being presented, we should really be considering whether the package of care that they have is appropriate or adequate, or if more serious kind of financial support and things is required. And so we should be considering, is there actually a rehab potential in using a powder? So in terms of maintaining muscle and dexterity, because we know that there's a sort of use it or lose it element to aging well. So can we as dietitians be considering kind of other functional elements when setting our goals? So asking patients if they can stand up from the sofa independently or make a cup of tea, because if they can do those things, they may be able to make up a powdered supplement and it could have positive benefits. And if patients are unable to do these things, then maybe we need to be looking, like I said, at those packages of care. And are they actually going to be able to eat and drink enough safely and independently? So looking briefly at the packaging of ONS, Sarah referenced it in the beginning. So I wrote an article for Dietetics Today last year. So I just wanted to touch on some of the learnings from that. There are about 300,000 ONS prescribed each year, and they're made up of between 5 and 7 components. So they might come in a bottle, a pot, a cup, or a sachet, but there are also other elements such as the lid, a seal under the lid, a cardboard wrap with and without a tray, and a shrink wrap. And so we need to take a holistic approach, and in an ideal world, we'd look at the life cycle analysis of a product. It's just that unfortunately this is not kind of readily available at the moment. A life cycle analysis, for those of you that are not aware, is a standardised approach which measures every stage of the journey from extraction and processing of raw materials, designing and producing the product, packaging and distributing it, its use and reuse all the way through to disposal, so whether it's being recycled, incinerated, or ending up in landfill. Manufacturers really have an obligation to consider all of these steps that lead from raw materials through manufacture, distribution and usage to their final disposal. And life cycle analyses, they give us an impact of a product on climate change. So not only greenhouse gas emissions, but also water use, land use, energy use, as well as looking at planetary health boundaries such as ozone depletion, eutrophication, and the impact on human health. But even life cycle analyses don't include everything, so they don't look at the sourcing and procurement of materials and any certifications such as the Forest Stewardship Council. And they also don't look at hazardous substances used, littering potential, and environmental persistence, which is how long a product remains in the environment. So breaking it down into the three most common types of packaging that you'd find with ONS, is your carton, your plastic bottle, and a sachet. Unfortunately, at the moment, there's no totally simple, clear-cut solution. You may have noticed that there has been a lot of move towards cartons for liquid products, because I think people assume that because they're made of cardboard, you can just pop them in with your cardboard recycling, and that would be that. Unfortunately, they contain a plastic polythene laminate and sometimes an aluminium layer as well, to kind of act as an oxygen barrier. So currently 68% of local authorities in the UK collect these products, these cartons, but of those 68%, 80% of them have what is called a mixed or commingled or two-stream process, which means, unfortunately, they're highly unlikely to be recycled due to the sorting mechanisms required. So less than 20% of collections of those 68% are multi-stream, which gives a high chance of them being recycled. Conversely, plastic, which we all want to be reducing for obvious reasons, because it's made of food grade plastic, so HDPE or PET, it's actually collected by 100% of local authorities and is easily sorted for recycling regardless of the collection method. And there is actually quite a high demand for food grade recyclate, which currently makes it a more effective recycling process.
Let me just come, sorry, I'm on this call. Let me just come out of that.
Sorry, I can hear somebody's not quite on mute. So it's not quite as clear cut as one would hope. However, we do want to be reducing plastic. So we really need to be pushing for infrastructure to support the recyclability of cartons. This is really paramount because you'll have noticed just going to any sort of supermarkets that all sorts of products are moving towards using cartons. And then in terms of sachets, we've already touched on the fact that they are going to have a lower carbon footprint because it's a much smaller product. And again, you might look at a sachet and think it's just made of paper. I can pop it in the paper recycling, but they also have a plastic and aluminium laminate. However, I've spoken to all the companies that kind of produce these sachets, and they've the majority have said that they should still be able to be recycled if they're put in with the soft plastics recycling that you find kind of at the front of large supermarkets where you'd put your plastic bags. So their life cycle analysis would probably be more favourable because they use less energy, less raw materials, less water to produce. And as Rebecca mentioned, all of the powders are produced in the UK. And so there's a lot less transport costs involved there in terms of carbon emissions. Although obviously that's not accounting for the milk used to make it up. But I think Rebecca touched on the fact that if you're sourcing milk locally, at least there's less of a transport element from there. So what can we be doing? We can be educating our colleagues and our patients and carers on the correct disposal of ONS products. So that includes things like discarding the seals under the lids because they can't be recycled, washing out the bottles, squashing them and then screwing the lids back on. And that's because the lids, they can't be detected by the machines. Anything smaller than 5 centimetres kind of goes undetected and so would end up in landfill. So put the lids back on and that helps the machines kind of detect and sort them into the correct stream. And obviously remove any labels from the bottles before you put them in the recycling, and they can go in with your soft plastics along with any sachets. And then the other thing, I guess, is just to kind of keep up to date with packaging and recycling developments. It may not feel like that's something that's like an area that you should be looking into, but I guess if we're recommending the prescription of these products, it's part of our care really, in terms of the environmental impact that our care is having. And then as a result of the article, the British Dietetic Association Sustainable Diets Group wrote to each of the 9 medical nutrition companies requesting that they commit to 6 standards. And they are to subscribe to on-packet recycling labels, which hardly any of them do at the moment, to promote the recyclability and correct disposal of their products, to join the UK Plastics Pact, which is a movement for fundamental change in how we design, produce, use and reuse and dispose of plastics, which is hoping to create a more circular plastics economy. Use recycled content in packaging, which would also promote closed loop recycling and would reduce the overall climate impact. Educate their staff on the materials and recyclability of their products, because again, in the research I was doing, nobody knew. They all had to kind of go off and find out the information. And finally, to declare their sustainability policy and roadmap to net zero, plus in an ideal world, the full life cycle analyses of their products. So in summary, Rebecca's touched on the fact that we do have the system that we currently have is one of oversupply and overprescribing. So it's just sort of being aware of that. And then obviously I know that we all try to do this, but just a kind of reminder of patient-centered care with meaningful goals and outcomes. So looking more at the feel, function and survive element that Rebecca touched on. And the practice of evidence-based medicine, including goals and outcomes. And I guess just being aware of any of that action bias that she discussed. And then if an ONS prescription is needed, as we know that it often is, just please to consider your local formularies, which will often kind of guide you as to which products are more cost effective as well. Consider powders as first line and think about the rehab potential that could come with the powders. And then finally, educating others on the recyclability of these products. So we've just put our references at the end there. I think this presentation will be made available at the end. So they're there, and otherwise I'll hand back to Sarah.
Just chip in at this point that I think it's worth also mentioning that in terms of experience of talking to patients about greener, more green choices, what's been your experience so far?
Oh, sorry, you're talking to me. Yes, I would just say sort of from an anecdotal point of view, because I work in prescribing support, that generally speaking, patients are very open to kind of opting for greener choices if they're kind of informed that there are a couple of products available and one is likely to be more environmentally friendly, for example. They are pretty open and willing to consider it, certainly, yeah.
Yeah, and that's certainly the case for inhalers as well, I know, because having looked at that evidence. So that's really encouraging. I just wanted to bring that in at the end.
Yes.
Wow, thank you, both of you, Ruth and Rebecca. That was very thought-provoking and detailed, and I hope gives the audience lots of points to think about, inspiration and potential actions as well. The slide that's up on the screen there just details some potential links that people might want to access, but if we could stop